Good morning, everyone, and welcome to this Behavioral Support Rounds workshop. I know a few people are going to be trickling in this morning. We do have a lot of people registered. My name is Stacey Guy, and I'm a knowledge broker with the Ontario Centres for Learning, Research and Innovation in Long-Term Care, or CLRI, and it's hosted at P.I.E.C.E.S. Today's workshop focuses on gaining a better understanding of meaning of behaviors in advanced neurocognitive disorders and better assistance in behavioral care planning and NCD. We, the Ontario CLRI, acknowledge that we live and work on Indigenous land. P.I.E.C.E.S and our related Toronto Central Local Health Integration Network behavior support programs operate on the traditional territories of many Indigenous nations, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. We recognize the current treaty holders, the Mississaugas of the Credit First Nation. This workshop is supported in part with funding from the Government of Ontario through the Ontario Centres for Learning, Research and Innovation in Long-Term Care, the Behaviour Supports for Seniors program, and the Toronto Central Local Health Integration Network. The views expressed herein do not necessarily reflect the views of the province. You will have received the schedule for today. Please note there are breakout rooms at 2 p.m. when we will be applying the principles to the case examples. Currently, we're doing the welcomes and introduction. It'll be turned over to Dr. Luthra at 9:10 for an overview. We'll have a break at 10:30. At 10:45, we're looking at the behavior categories. At 12:15, we'll have a break for lunch. And then at 1, we will come back for the application pieces and some more learnings from Dr. Luthra, and aiming to close by 3 o'clock today. So that's a brief overview of the schedule. I would now like to pass this over to Einat Danieli. She will be introducing our workshop presenter. Over to you, Einat.
Thanks so much, Stacey, and thank you to the whole CLRI team for the work that you've been doing behind the scene to make this day a success. Behavior Support for Seniors program is really delighted to collaborate with CLRI and Dr. Luthra and his team at McMaster University to provide this workshop today. Dr. Luthra is presently an associate clinical professor at McMaster University, Hamilton, Ontario, Canada, in the Faculty of Health Sciences Department of Behavioral Neuroscience. He is also affiliated as a research scientist with the Research Institute for Aging, Schlegel University of Waterloo and Ontario. He is currently working in the capacity of medical coordinator in the program of older adults at Humewood Health Center in Guelph. And he is also affiliated in the same capacity with the St. Peter's site of Hamilton Health Sciences in Hamilton, Ontario. His clinical and research focus is on developing safe pharmacological and affordable non-pharmacological treatment interventions for behaviors in moderate to advanced dementia. I've come to know him as very humble, but I'm very excited about the knowledge that he's going to be sharing with all of you today. You know, I think it's as clinicians and as health workers, I think it is our duty to constantly question, and especially in the behavior support business, so to speak, it is our duty to really question the way that we do things, our approaches, the tools that we use. And Dr. Luthra is going to take us exactly on that journey today. And I think it's going to be fascinating and interesting and enlightening. So I really welcome everybody today. Please sit and relax, take care of yourself and enjoy the day and absorb as much as you can. Dr. Luthra, the stage is yours.
Good morning, Einat. Good morning, Salma and Stacey. I'd like to begin by first thanking you all for giving me yet another opportunity and um, the platform to be able to share some of my work, which I have been doing for some time. And we have a long day ahead of us. I know there's a lot of information that's going to come your way, which perhaps may be the first time you're hearing this information. But again, the idea is, as Arnett said, sit back, soak it in as much as you can. And then, of course, I do have a website where you'll see bits and pieces. And hopefully over time, I should have my second edition of the book as well. So I'm going to begin by taking us through a brief journey, which is where we initially started when Einat approached me, or I approached Einat to start this, in terms of taking a step back, taking a look at what we're doing, and then sort of moving forward into where we could possibly be heading. So obviously, this is a statement from J.R.R. Tolkien, where he talks about not all those who wander are lost. And that has become my motto when it comes to uh, understanding end stage dementias with behavioral expressions, in that we find these people are obviously seen to be wandering, and we think not much of it at times, but the reality is it's all about us trying to understand what is it they're trying to tell us, what is it they're trying to communicate to us through their wandering. That really is the essence of what we do, and how best do we help these people who are wandering. So obviously, we're going to start by talking about some of the diagnostics and stuff, and understanding what this all means. So basically, we're going to start out with some of the very basics and then work our way up from there. Now, in order to understand the meaning of behaviors in neurocognitive disorder, and trying to get a better understanding of this LuBAIR paradigm, I think it's important for us to take the journey that this part of literature has over the last 15 to 20 years, in order to understand where we are today and how we got here before we move forward. And so what's important is to understand the diagnosis of behavioral and psychological symptoms of dementia, which was the DSM-4, and now it's called behavioral disturbances, which not particularly fan of that, neither was I, of BPSD, of behavioral expressions, as I call it, because these are indeed expressions of specific individualized behaviors, which means something. It's really a diagnosis of exclusion. And what that really means is that in order for me to be able to rule in someone as having behavioral expressions, it is very important for me to rule out that the presentation that they are there with is not because of organic mental disorders. And the most common example of that, of course, is delirium. And of course, the what you're observing in a resident is not because of an underlying mood disorder, anxiety disorder, or psychotic disorders. It obviously is not because of any physiological determinants in the body, and neither it is because of environmental disturbances. So it is important that we make sure that each of these underlying conditions have been ruled out before we can rule in behavioral expressions, or else if any of these are responsible for behavioral expressions or the presentation of those behavioral symptoms, then we cannot label them as having behavioral expressions. And it's very important to understand this. So in other words, labeling is that of exclusion, not of inclusion, and we must take that approach. And this is really the gold standard in DSM. As you know, you've all heard about the DSM that we all must adhere to. We have our own opinions about DSM, but not necessarily we all tend to agree on those opinions. But regardless of what the opinions are, this is the gold standard, and we must adhere to this. And basically, diagnostic and statistical manual, starting from 3 to the present day 5, they all talk about the the diagnoses of behavioral expressions as one of exclusion. And that really is a framework that was adapted from Cohen-Mansfield. You know, we all are familiar with the Cohen-Mansfield agitation inventory, and she was the one who really first posited that in order for you to label something as being agitation, it is important that you eliminate it is not because of delirium, not because of a depression, not because of an anxiety disorder, or not because of a psychotic disorder. It's not because they are hungry or they need to void. And it certainly isn't that there is a music playing in the background that's irritating the hell out of them and therefore they're agitated. So the agitation word, which became obviously later responsive behaviors, and now my preference is behavioral expressions, is all derived from the Cohen-Mansfield paradigm, and that paradigm being that of an exclusion. So how do we approach this in our clinical practice? Obviously, you know, anytime you and I get asked to, you either as a part of the BSO organization or PRC, or as a lead in your various respective agencies or organizations, you know, what we do is we take a very simple approach. The simple approach is we try to obtain a history. After we've obtained a history, if our training allows us, we will do a mental state examination, and then of course, physical examination if necessary, and some investigative workup. And then we take all the positive findings from our history and examination and we apply them to DSM criteria and make sure that those positive findings are not fulfilling any of the criteria for either delirium or a major depressive episode or a generalized anxiety disorder or an atypical psychosis or etc. And then if that's the case, then it is ruled in as a behavioral expression. But obviously, the simple and the most important thing in all of this is that the person you are now interviewing or assessing must have a preserved intellectual abilities, because they must be able to recall information, they must be able to give you a reliable and a valid history, and at the same time, your mental state examination should also be reliable and valid. Obviously, the problem is that the people we deal with, the individuals we deal with, and the cohort of individuals we deal with, where we find these behavioral symptoms and not behavioral expressions, behavioral symptoms are the most prevalent or the highest are in the advanced stages of neurocognitive disorder, which by definition is MMSE of 12 or less. Now, I don't have to tell you that it obviously brings into question the reliability and the validity of a clinical assessment in an individual who has an MMSE of 12 or less, because clearly by this stage, many of them are even their language functions are also not preserved and they cannot even engage, let alone form sentences or let alone remind you what they did the day before, or recall for you the chronology of the evolution of symptoms. So clearly, this is a huge issue, and this is where, guys, want you to understand how P.I.E.C.E s came into the interface, and P.I.E.C.E s obviously was posited by the person I consider my mentor, my guru, Dr. Ken LeClaire. And basically what he was saying is that when he went into a long-term care facility and he started having a conversation with the nurse and asked if the patient was quote unquote agitated as defined by Cohen Mansfield, and not agitated as just being restless and unsettled, then he was getting all different kinds of answers, because clearly the frontline staff were simply seeing agitation as an agitation of motor restlessness and pacing and wandering. But when he went to say, is the person agitated, in his way of thinking, after application of DSM criteria, he wanted to make sure that the person who's a frontline has ruled out delirium, depression, anxiety, psychoses, and all the other things. So clearly there was a disconnect that he found, which obviously I can assure you is rampant even today after 20 years of this being in place. But that was the purpose of P.I.E.C.E s. What he said was, I must bring something to the frontline staff and help them understand that there is a framework they must follow in every individual that gets referred to them, and that framework was P.I.E.C.E s. So it really was an extension of DSM framework, so that I, as a clinician who's been trained on a certain model, and you individuals as frontline staff are all on the same page. And of course, this is where we talk about is physical. We want to make sure that all the medical and the physiological determinants of the presentation have been identified and addressed. And of course, in the, in medical, it ranges from infections to metabolic disturbances to acid fluid balance disturbances, to all those things. And physiological could be as simple as someone who has severe fecal loading to urinary retention, or having a very high post-void residual. So basically, physical P had to be addressed. Emotional, of course, it meant that mood, anxiety, and psychotic disorders could be eliminated. E in this was the environmental or the milieu. And of course, S was the social, which was the interpersonal, psychosocial, familial dynamics, et cetera, et cetera. So basically, when P.I.E.C.E s was introduced, as you can see, there are still two alphabets missing in this, which is I and C, and that has a different purpose in P.I.E.C.E s. But when it comes to taking an approach to assessing behavioral expressions in individuals with neurocognitive disorder, the purpose of P.I.E.C.E s is exactly what I get trained to do. And of course, P.I.E.C.E s makes it that much easier to understand and approach. So absolutely a brilliant piece of work. And of course, later on in the revisions of P.I.E.C.E s, the S also became the self, which is emphasis being added to that you must try to understand the individuals who is carrying the disease. And I'll talk about its relevance a little bit later. But at this point in time, so here's the approach. When it comes to the physical, what we do is clearly in our tool set that we'll do the labs, we'll do the investigations, and then one of the tools available to us, because we know delirium is one thing we must rule out, is the confusion assessment methodology. Now, here's where we have a challenge. I don't know many of you know this or not, but this particular tool is only valid in its application to individuals who are non-cognitively impaired. So basically, these people have no cognitive impairment to begin with, and then they show an acute change in their presentation. And then that acute change is caught by the criteria, the screening tools of confusion assessment methodology. It certainly has no established validity in advanced dementias. There are certain variations of this tool which are available. For example, in intubated ICU patients, but really when it comes to advanced dementias, now there is some evidence to suggest in the mild stages, and I agree with that, it is still very valid. But when it comes to advanced stages, there is absolutely no validity. And this is really what we use every day, guys, in all the residents we get called to see, who are literally in their MMSCs of 5, 7, 10 on a good day, and applying a scale that really ought not to be, because simply by the end of the day, it still has the same premise. The individual has to be able to engage, or you ought to be able to establish certain aspects of that. Now, the emotional part, what we do, obviously, we talked about the emotional component of P.I.E.C.E.S is to rule out mood, anxiety, and psychotic disorders. But the part that we use every day in our clinical practice is the Cornell Depression Scale. And I want to talk a little bit about this. So the individual who was responsible for establishing and validating this particular scale, and this was done back in 1988, Alexopoulos, he basically had said one very simple thing. He said, Cornell scale is a quantitative measure of depression. And what that really means is that you and I must first make a diagnosis of clinical depression in a clinical assessment, in a clinical interview. And then once we have given the diagnoses, then this particular scale is responsible for establishing the severity of the clinical depression. It is never meant to make a diagnosis of clinical depression. And again, in order to make a diagnosis of clinical depression, you must have an individual who is valid, who is preserved in their intellectual abilities, in terms of engaging. So clearly, we obviously have been attempting to do something which it really isn't meant for. And I'll tell you the most significant part of this was what happened 2 years ago. And some of you may have heard of this, is there was a very big study after lots of money spent where they said they took 2 antidepressants, I think it was Wellbutrin and Remeron, in patients with dementia, and they used the Cornell scale and said, let us see which of the 2 medications are working and is there a difference between the 2. And obviously at the end of the study, they found that neither of those 2 medications were effective in treating depression. Now, and I know that to me, that was a shocker, because we all recognize that we treat depressions in dementia, but it is, you start out with the wrong premise. Just take a scale which was never meant to diagnose, only meant to establish severity, and you conduct this very expensive study, and at the end of it, you're told, well, no antidepressants work. It was very discouraging, but obviously it was done and it was established. So clearly we have to think again how we utilize this particular scale. Then, of course, in the emotional part, the part that we do not use and we don't have in our clinical toolkit is the neuropsychiatric inventory. And the neuropsychiatric inventory classically has been utilized. It was established by Cummings et al. In 1994, again established in 1997. And basically it is used to identify anxiety and psychotic disorders. And in our clinical practice, in our toolkit, we really don't have anything we use specifically for those two. So in some ways, we don't know if any of our residents have a variant of an anxiety disorder that is responsible for the way they are conducting themselves, as we do not really assess this. And now the other part, of course, is this itself has its limitations, because one of the things it has been established on this inventory, I mean, it has limitations. It has limitations even when utilized in individuals who have preserved intellectual functions. And let alone that there is yet a sort of questioning around many of the subscales, et cetera. But the fact is, even in preserved individuals, there are major issues, and there really hasn't been a testing done on the advanced stages of neurocognitive disorder. And then, of course, we have the environmental and the social, and we're all familiar with the ABC analysis. I mean, the antecedents, the behaviors and consequences. I recognize that this is one of the most tedious aspects of our evaluations, and I frankly see it being done less and less and less and less, simply because of the time involved. When I started this, I would often see people having these ABC columns and working, and now I rarely see this. So if it's being done in a different modality, I do not know. But what I do know is the traditional framework of ABC is being used less and less. I think people are more relying on clinical observations and clinical history, and nothing wrong with that. It's equally valid. But the fact is it being overlooked in certain cases? So in essence, what we're really saying is that if the reliability and the validity of the clinical evaluation in individuals with advanced neurocognitive disorder is to be brought into question, and all these tools we're using have not been validated, then what does that mean? And this is really where the literature started to shift about a decade ago. In some very wise people started to say that, guys, listen, this is not working. And this is when I sort of got on board with the shift, saying, we do this, we've all trained from the same book, but this is not working for me. I'm getting tired of putting all this time and effort into this, and I am not able to deliver what I need to deliver in a measurable way, which I call success, in 80% of my patients. And 20% it works, because, I mean, I'll tell you why it works if ever we have a chance to talk over wine. But otherwise, the diagnostic formulation was not working, or in some ways, I mean, happy to say that the quote unquote, the medical model was really not being very effective. And you guys have been struggling with this, and at least one of the feedback that I have been receiving from some of the recent presentations I've done with the cohort at Baycrest is that, and it's a validation for me that I wasn't the only one who was struggling. You guys were struggling as much, and you guys were saying, I don't know, this is not working, but I don't really have another thing that's working for me. So clearly this is where it started to shift. So until this point, until about 10 years ago, it was basically, and the terms you may remember, behavioral disturbances, all sorts of terminology was used for the presence of these behaviors, and the terminology had a very negative connotation. And we know even today, a vast number of times when this term is used, outside of people like you and I who live in this world, it's still used with a very negative connotation. But the literature started to shift, and the literature started to say, guys, let's not look at the presence of behavioral symptoms as a problem. Let's take a step back. Let's take a look at what is the reason for their presence. And if there is a reason for their presence, we have these individuals who are advanced stages, And we have these individuals who are not able to communicate in traditional ways because their language functions are not preserved. Then if there is a reason, then is it possible that reason is a mode of communication, i.e. the residents with advanced stages are trying to communicate to you and I that this is what is going on. And because they cannot help expand, basically putting it in our laps to say, guys, try to figure it out and try to help me. And so this is where my journey began, is to say, what is being communicated to you and I through their behavioral expressions, and therefore trying to understand the meaning of these behavioral expressions. So, and this is where I'm going to bring back two very, very critical things here. The first is, what is the framework? To understand the meaning, to understand the, um, the reasons for their presence. As I said, pieces in its revised versions, S, other than being social, also became the self. And the self was basically the emphasis being put upon the fact that there is a person, there is a human being that is carrying this illness. Try to understand who that human being was and see if there is any way you can then make some interpretations, extrapolations of what you see today at this stage of their disease when they cannot communicate with you, if they are communicating a part of who they were and what they were. And of course, the most substantial from my perspective, I mean, again, everything about GPA is brilliant, but the most substantial part that I find to be is the concept of introduction of personhood, because that completed the picture as far as understanding the person is concerned. And of course, if you look at the literature and if you look at the definitions of personhood, you'll find that it really is the biopsychosocial being, or the state or fact of being of an individual. So clearly, one word that is packed and that is so exhaustive in its interpretation that even though the concept was introduced, I still did not have a framework. And because we didn't have framework, the danger there was that your interpretation of whatever was happening and my interpretation of what was happening may have never been on the same page. And of course, when that happens, clearly the person who suffers the most is the resident, who is not able to communicate and now is being misinterpreted. No, I wouldn't say is being interpreted in 15 different ways depending upon which hands they go. So, the frontline staff thinks something else, the registered staff thinks something else, the BSO and PRC come in, they think it's something else. And then, of course, the consultants show up and they have their own theories. So now nobody's on the same page. So even though the concept was established and absolutely worthwhile, framework was missing. So in order to understand that framework, in order to establish that framework, I had to go through a lot of many different steps, which we're not talking about here. But the one thing I had to do was I had to start out by initially establishing a way of collating, a way of understanding brain and the way of understanding behaviors in normal individuals. Because when you understand a model in normal, you can then extrapolate to abnormal. And when you extrapolate to abnormal, then at least we're all talking from the same language. So in order for us to understand the personhood, in order for us to understand the meaning, it had to begin at the basics. And I know there is a chunk of presentation here that's missing, so you're just going to have to trust me that this is the way I have to. So moving on to brain and behaviors, I'm going to take you through the very basic. Now, brain and behavior, or brain itself, as most of you know, is probably one of the most complex areas of the body. And you know what? There is so much done, yet we know so little, because it's just absolutely amazing what the brain is able to do and what we all take for granted. But I'm going to start out by breaking this down into some very simple concepts. So basically, we're going to break down the brain and the behaviors into body circuits, and then we have brain circuits. And I want you to focus on the word brain circuits, because I'm going to talk about something else in a few seconds. And then, of course, we have brain function. So here is the body circuits. Now, when you look at the body circuits, it is your entire body on the exterior and the interior is innervated with gazillions of miles of nerves. And all of this information basically enters the spinal cord, as you can see, at different levels of the spinal cord. And then from there, it gets taken to the brain stem. And from brain stem, then it gets dissipated to the entire brain and different parts of the brain. So body circuits in many ways are called the peripheral nervous system. And of course, the brain itself is then alluded to as the central nervous system. And the three sets of nerves you need to remember is the sensory nerves, the motor nerves, and the part that's missing in here are the visceral nerves, the nerves which are innervating all your internal body organs. They also follow the same pattern. They also enter the spinal cord at their respective levels for the information to go up. Now, the brain circuits is a concept I want to talk about. In the 90s, late 90s, the neuropsychologists who are responsible for helping us understand the evolution of brain connections and brain functions had basically said, let us stop talking about the lobes of the brain. Let us not say parietal lobe and temporal lobe function and frontal lobe function, et cetera, because all of that is really not an accurate representation. What they basically said is every function in the brain that happens, it does not belong to a given lobe. What it belongs to is an exhaustive circuitry. So any function in the brain has a circuit that transverses through every lobe in the brain. So there is always a certain part of the brain in occipital lobe that may be responsible for a function that you and I may have always thought was a frontal lobe function. And we all know that it is way more complex than just a lobe, because you can have a brain infarct of the size of a tennis ball in the parietal lobe and have no deficits whatsoever. And you can have a minor pinhead stroke in the frontal lobe, and it desecrates your cognitive and motor function. It is because it isn't about a part of the brain, but it is about the circuits in the brain. So I have not talked about lobes in the brain for about 20 years, because that is archaic, that is irrelevant, and it is the circuits we need to understand. And these are very complex circuits. But the other part, of course, is the circuits, unlike the circuits in your television or your iPhone, is that if one component of that circuit burns out, the whole circuit goes dead. That is not the case with the brain circuits. That is where we talk about the brain plasticity, where you can have one component, you can have a stroke in one component of that circuit that may be lying in parietal lobe, but you still have absolutely preserved cognitive functions because other parts of the brain around before and after pick up and compensate for that deficit. So that is why it's important to understand. And the four brain circuits that we are going to talk about in general, there are others, but the big four ones is the first one, which is the information processing circuits. Then we have the motivational circuits. We have the emotional regulatory circuits and self-monitoring and regulatory circuits. So self-monitoring and regulatory circuits. Information processing circuits is the holy grail of what you and I do. When we talk about dementia, when we talk about understanding cognitive impairment, and this is what we need to understand. This is a very broad representation of information processing circuits, and I've given you 4 or 5 steps, the big steps, and you can call them relay stations. These are all subserved by different levels of the brain and different parts of the brain. But in essence, what I have done here is showed you from vision to hearing to smell to taste to touch, the visceral nerves, the sensory and the motor nerves, all of them coming to the spinal cord and travel, or they go directly to the brain, as are the vision and the hearing and the smell. You know, the touch is all the way through from long distance, but some of them have short access to the brain. You know, they end up going to a certain part of the brain where you form sensory memories. Then you go on to the next part of the brain where you form working memories. Then you go to the other part of the brain where you have long-term or stored memories. All of this information moves to an association cortex, and that is where we give meaning and a purpose to everything that happens. So all this information, and it's a very complex procedure, but the only thing you need to understand is think of this as the information being dropped on this information processing highway. And then it has to travel on this highway to get to where it needs to get to for it to be processed, which is the association cortex. And this information processing circuits, their preserved function is responsible for the generation of higher cortical intellectual functions. So basically, information processing circuits must be preserved for you to have normal intellectual functions, and these are the normal intellectual functions that we as human beings, we have executive, we have visual spatial, we have memory, we have language functions, we have praxis functions, we have meiosis functions, and of course, insight and judgment. And that is important to know. So this is where we have to understand what is dementia. Dementia is the condition where, for whatever reasons, whatever the cause, whatever the etiology, the information processing circuits are impaired. And when the information processing circuits are impaired, depending upon the stage of the disease, depending upon the severity of the disease, depending upon the severity of the reasons for impairment of information processing circuits, will determine the severity of dementia. So what are some of the common reasons for dementia? You know, we've talked about the commonest reasons that you all would hear about are proteins. Protein, basically, it's as simple as in your brain, there are certain types of proteins which are formed and then they get destroyed by the end of the day. So it's almost like, think of this as in the beginning of the day, these proteins are formed, they are utilized through the day, and then by the end of the day, they don't want any extra laying around because they like fresh stuff, and so it has to be destroyed, and then for the next day, there is new formation. And when there is an imbalance of this protein formation and destruction, there is abnormal collection of proteins. And that abnormal collection of proteins is the deposition of those proteins, which causes dementia. And the commonest example you guys hear about are the amyloid, or we talk about the amyloid hypotheses of Alzheimer's disease. And then, of course, we have nucleotides, which are responsible for Parkinson's. Then we have the tau and the tau proteins, which are present in frontal lobe dementias and those kinds of things. But again, the commonest reason is the proteins. And the second commonest reason are, so now we're talking about the causes of impairment of information processing circuits. So imagine there is protein deposition along that highway that carries the information. And the more barrier it drops, the worse the information flow, and therefore more the dementia. And that happens, and any protein in the brain can do it. Now, the other ways that information processing pathway can be impaired is vascular, whether it is little strokes, when, we call mini strokes, you've all used that. Mini strokes basically means there are little potholes, but hundreds of potholes on the highway all the way to the core part of the brain, which is the association cortex. Or you can have a big stroke. You have a crater, the road gives. There's a separation of the road for that reason. Or the same effect can happen if there are bleeds or leaks in the brain. When there is a bleed, if there is flooding on the highway, cars cannot pass through, and when they cannot pass through, they cannot reach their destination. Similarly, imagine on the highway, there are now bleeds and leaks, which are happening, and therefore the flow of information is halted, and therefore you have cognitive impairment, or you can have hypoxia. When people go into cardiac arrest, and we often talk about, well, what is the possibility of someone with cardiac arrest being resuscitated in advanced dementias? And we always tell the families, listen, it isn't about resuscitation and bringing it to life. It is about how long will it take for them to come back to life. And every minute of hypoxia is devastating to the brain at that stage of the disease. So what may have been advanced now becomes beyond a vegetable. And so that is another reason why you can have. So now we're talking about, again, there is a processing pathways and what are the causes of impairment. There are the proteins, then there is the blood flow and its problems. And then, of course, we've got other reasons. We talk about trauma, head injuries, same thing. When you have trauma, you have a little bit of petechial hemorrhages. When those hemorrhages fibrose, they sever the pathway. They create these little bumps along the way on the highway, and therefore, same with toxins. What happens with alcohol, other toxins? What happens with B12 deficiencies, and what happens with other metabolics? So the important thing is, so that you all understand what dementia really is the abnormal functioning of information processing pathways. And I made it look purple because Purple Rain is my favorite song. And think about this, think about Prince. He wasn't demented, but close to it, but a brilliant person who, So make that association as to the, the pathways or the circuits and the causes of dementia. So what happens? This is what happens. And the reason why we do what we do in terms of mini mental state exam and Montreal cognitive assessment exam is that you are now looking for the impact of the impairment of the information processing pathways on higher cortical function. So depending upon how much protein got deposited, depending upon how many floods were along the way, or how many breaches because of strokes, etc., you can have the severity where you can, that's why we talk about dementia. Initially, it is the memory that goes, this is how it is. But that isn't the case if, for example, it isn't a protein, particularly amyloid hypothesis. In people who have stroke dementias, you can have relatively well-preserved memory and have other, because wherever the strokes happen is where the impairment happens and whatever the circuits are involved in that. And so this is, for example, the advance of the people that we deal with. This is their clock drop. And obviously, I think it's reasonable to say that these individuals cannot be engaged in a valid assessment. So again, to recap, information processing pathways are the primary brain circuits which are responsible for the development of neurocognitive disorders. We've talked about the causes, and then we've talked about the severity of those causes determine the staging of the disease. So let's move on to the next. So in essence, what's important is that information processing circuits have to be preserved for all the other three circuits to function normal. And the next one in this that we will talk about are the motivational circuits. And I want to, for you guys to think for a minute. You're all familiar with cognitive behavioral therapy. Now, cognitive behavioral therapy really is based on a very simple premise. And that premise is thoughts are critical. And the primary things you and I, if we work in mental health in addition to dementia care, we must hone in on, because thoughts are the ones which are responsible for generation of emotions. And emotions are the ones which fuel, they are the energy for manifestation of behaviors. So thoughts, emotions, and actions. That is the paradigm of cognitive behavioral therapy, but really thoughts, emotions, and behaviors is the paradigm for human function. For you and I to function every day, we must have preserved intellectual functions, which means we must have preserved information processing circuits so that the thoughts can be formed normally, whatever normal is for you and I, or whatever the definitions of normal is. And generation of thoughts is governed by motivational circuits. And that is the important thing. The generation of emotions are governed by the emotional regulatory circuits, and the generation of behaviors and modification of behaviors are regulated by self-monitoring and regulatory circuits. So think of this as a layered cake. At the very bottom is the information processing. Next to it are the motivational circuits. On top of the layer is emotional regulatory circuits, and then on top of that are the self. So it's like a 4-layered wedding cake. But the bottom layer, which is the information, is the critical thing that must be preserved, for all the other layers to actually taste good and normal function. So, this is, of course, just another way of saying that the brain circuits, then you have brain functions, and we've talked about the paracortical, the thinking functions, the emotional functions, and the behavioral functions. And so this is what we were talking about earlier, which is you have to have preserved purple in order for that purple to engage with the environment, for it to lead to formation of thoughts. And so it's important to understand how thoughts are formed, because we all take it for granted, but this is a very, very complex situation. So this is what happens. The motivational circuits, which are responsible for generation of thoughts or for a normal thinking function, need to be preserved. And for them to be preserved, the intellectual functions or the information processing circuits must remain preserved. And it's the preservation of these motivational circuits, which leads to the detection of what we call as a discrepancy between my inner world, which is my physiological and psychological state, and my external world. And it's that discrepancy which leads to identification of a need in that moment. And it is imperative for that need to be identified, because this is what happens. The needs get identified, which then get represented as thoughts. The thoughts then get formed into goals. When goals are formed, then there is activation of the motivational circuits to generate energy and motivation to go meet or satiate those goals, release the need. And as an example, all of us who work in healthcare, it's very, very common for us, particularly if we are working on an inpatient unit, and at least the PSWs and the nursing staff amongst us who, can be run off their feet. Imagine having to look after a certain number of people. You're working on the, say, 3 to 11 shift, and you had a very difficult start to the day. You come to work, you missed your lunch, and you start working. You've got to get all these people ready and everything else. And you're so caught up, you're not aware of what's happening. And then all of a sudden at 4 o'clock, one of the family members shows up with a bucket of KFC. Now, as soon as you get the whiff of that bucket, so the environment is now full of a smell of KFC, and the internal state of your body physiologically is that you have not eaten, you are food deprived, then all of a sudden there is recognition of a need. And the need is, I have my appetite. And so as soon as the need is recognized, the next formation of thought is, I need to get some food. And once we say, I need to get some food, then of course we say, okay, who's gonna cover for me? I'm gonna run to Timmy's, and who wants what? And then you go, you bring back the food, you eat it, and then your tummy is full, and then you're not hungry after that. And after that, you can have people coming in with 10 more buckets of KFC. But now your internal state is satiated, and it doesn't matter what smell it is. There is no discrepancy, and therefore there is no formation of a thought, which does not lead to formation of a goal, and hence you don't need to push it. So remember, motivational circuits are responsible for the thoughts and the goals, and that is how thoughts in our minds are. And so that obviously requires the information processing circuits to be normal. Otherwise, the thoughts, if they are not normal, the thoughts being formed will be accordingly distorted. I don't like using the word normal and abnormal because I don't know if I've ever met a normal person in my life, including myself. But in essence, what's normal for them. So now you've got the thoughts understood and the formation of the thoughts. This is what happens next. The information from preserved intellectual function and the motivational circuits or the thinking function then move the information to the part of the brain where we have emotions being formed. And that part of the brain is the limbic circuits. Now, we've all heard about the limbic cortex. Again, this is a prime example that limbic cortex has a piece of every part of every lobe of the brain times 10 over. You know, the circuits could be starting at temporal lobe, go to parietal, go to occipital, come back to frontal, go back to temporal, go back to parietal. It's a complex circuit because that is what it is. But what's important here is to understand that because emotions is more complex now, it also has a very complex bidirectional relationship with the higher cortical circuits or the self-regulatory and monitoring circuits. So imagine the preserved into the information processing circuits leading to and the presence of preserved motivational circuits leading to generation of thoughts which get fed into this. And once they get fed into this, then the emotions have to be congruent. So you cannot be having sad thoughts and having happy emotions. So the emotions are always congruent to the thoughts. And that congruency can only happen if the emotional circuits or the limbic circuits are also preserved and are normal. And so in essence, what is happening is when it comes to emotions, the two things that happen simultaneously are the generation of emotions in the limbic circuits, and then it's bidirectional feedback so that there is regulation of emotion. So if you have thoughts of, gee, you missed watching a movie you wanted to, and you're sad over it, and then your emotions are sad, but they're also regulated and congruent to the degree of loss. You're not gonna be having a 10-hour emotional breakdown because you couldn't watch a movie. So there is that part of generation and regulation of emotions, which is that complex relationship between the limbic circuits or the emotional circuits with the self-regulatory circuits, which are in the higher cortex. And they both occur simultaneously. So now we go to the final part of this, which is the behavioral functions. So in essence, what happens is you have to have preserved intellectual circuits, you have to have preserved motivational circuits, you have to have preserved limbic circuits in order for all of this to be put into associational cortex for it to lead to formation of actions. And it is those actions or behaviors which are a manifestation of everything that has happened beneath. So bring it down to the simple understanding of intellectual functions and remember the cognitive behavioral paradigm, which is thoughts, emotions, and behaviors. So intellectual functions leads to preserved thoughts, leads to preserved emotions, leads to preserved behaviors. And this is the way to understand normal functional model of the brain. And here it kind of represents, and again, it kind of goes around, but I wasn't able to. I'm not a very good person with technology, and my research assistant's off these days, so I couldn't get a layered cake presentation of this. But in essence, the most articulate way to demonstrate this is in layers. The bottom layer, which is the fundamental layer, it is always the thickest layer. You don't put the thickest layer at the top in the cake, and then the subsequent layers are there, but you need every one of them for the one at the top to stay at the top, not collapse. And so that is the functional model of the brain. And so let's take it back to that bird's eye view of what we've talked about. Body circuits, you have brain circuits, and you have brain functions, and all of this comes together. Now here I'm going to throw in another concept. And this concept here is the concept of sensorium. And so consider sensorium as being a halo that is sitting on your head all the time. And sensorium is the gatekeeper. So even before the information gets into your head, and even before the information gets dropped onto the highway, the information processing highways, it has to go through the gates of sensorium, and sensorium is the gatekeeper. And it's important to understand this concept because this is the key, absolute key to understanding your residents and how to help them. So this is another picture presentation of that with the sensorium sitting at the top. So consider if this was in the form of a layered cake, then sensorium would be the umbrella at the very top. And it is the one that, you know, if it's covering, you cannot take a knife to it because you have to first cut the umbrella. So what is sensorium? Now, sensorium basically is a very simple construct. And it is a construct that talks about the level of alertness or arousal. So sensorium basically is a concept of level of arousal and its dynamic relationship with your level of attention. As simple as that. So there was a slide that obviously I missed in here, which is it talks about arousal plus attention equals sensorium. And each of these, arousal and attention, have a very specific purpose. But remember, what's important is just having an abnormal attention is not an impaired sensorium. And impaired sensorium only happens when arousal is affected and its congruent effect on attention. And we'll talk about that a little bit more. But let's talk about arousal and what is the purpose of the arousal and what does it do? So basically, arousal is really a state of wakefulness. By now, as you know, many of you are probably drifting away and your state of wakefulness is dwindling. But I want to remind you, we have till 3. If I'm going to suffer, so are you. So, so don't bail out on me in today. So the level of wakefulness is what it's all about. And for anybody who wants to be more technical, you may have heard of the reticular activating systems in the body. These are the ones, and when you drink coffee, when you drink Coke or Red Bull, that's where you're hitting. And it is the state of wakefulness of your psychological and physiological domains. And remember, guys, I am repeatedly here referring to psychological and physiological because they are both same in a human being. You can't separate the psychology from physiology. They are intertwined, overlapped constructs. And so what is the purpose of being alert? It's actually very simple. The purpose of being alert is twofold. The first purpose of being alert is if there is a trigger, how fast you react to the trigger. It's almost like if any of you understand photography and you have a shutter speed, if it is slow, and by the time you click the camera, the object you're trying to click is gone long before the shutter opens and closes. So basically, the reaction to that trigger is not right. And the state of wakefulness is responsible for the shutter speed to be normal. So when you see a stimulus, you look at it in right timelines. And the second is once you look at that trigger and you pick up that information, then it gets dropped onto the information processing highway. And then how fast it goes on that highway. There is a normal speed of it going to where it needs to go. There is a slow way of getting there or too fast a way of getting there. And neither a slow or too fast a way is healthy because too fast leads to crashes and too slow misses the boat. And so it's important. Something as simple as arousal is critical to those two things. So let's look at attention. Attention, again, we all take it for granted. It's a very complex issue, but what is the big purpose of this? The purpose of attention is to look at this, it's to pick up that chunk. It's how much of the pizza you bite at one point in time to chew. That is the purpose of attention, is when you look at something, you pick up that chunk of information. So now if you look at the combined effect, which is that if you have an altered sensorium or an impaired sensorium, let's say the impaired sensorium is slow. If the sensorium is slow, by the time you react to a stimulus is slow. Now your attention is obviously slow, and therefore the chunk of information you pick up will be not sufficient. And then once you've taken that information and you put it on the information processing highway, it's slow, it's very slow to travel. And all of this is hugely, hugely important. To give you an example, you and I have had times in our lives when we may not have had good sleep. We may not have slept well for any number of reasons, whether it's for worry or for whatever. And then the next day we go attend workshops. And what happens at different times of the day, we have this wave of mental lethargy that floats in. So as soon as that wave of mental lethargy floats in, it impacts on my attention and it impacts how quickly. So if someone is presenting, if I'm slow, they've gone on to slide 10 and I'm still trying to process slide 1. And of course, what that does is the attention is impaired, how it travels is slow. And so if you ask me 10 days later, well, how did you find that workshop and what did you think about this part of it? And if that part of it was because I was in that wave of mental lethargy, I may not remember any of it. So sensorium can impact on your cognitive functions, even if you do not have cognitive impairment. Similarly, many of us have been in those positions where trying to cram for your exams, drinking equivalent of Red Bull, which were not there in our days, and being all hyper in arousal. You know, you're waking up, and we used to marvel at these people who've gone 4 days without sleeping before exams and cramming everything. And then they show up at the exam to see the question. They know the question. They know damn well they've read the books. They draw a blank because what happens? Their arousal was hyper, which meant their attention was distractible. And even though they thought they were reading, which they were, the information was traveling too fast to the brain. It was crashing and nothing was being registered. So by the time you get to the exam day, here you are thinking you've read everything, you've done everything, you went through the whole book cover to cover, should be no problem. And chunks of that book you have no recollection of. So see how sensorium can be slow, can be fast, and either way is not good for you. So what does that do? This is what happens, is when you have problems with sensorium, then basically it significantly drops your task performance. Whatever task it is you are doing, I use the example of memory, but the reality is it could be anything. Now imagine if you have cognitive impairment. And by definition, cognitive impairment is a state of diminished competence or diminished performance. And if you subject that person now to changes in sensorium, their functioning will drop even more. And now apply that to someone who has an MMSE of 10. Literally, it could drop to MMSE of 1, even if there is a slight alteration of their sensorium. So sensorium is the halo that sits at the top of your brain. And so this is the functional hierarchy model of the brain. And I just call it the SITA model, SITA, which is sensorium comes at the top. So sensorium must remain normal at all times. And then intellectual functions, which means the information processing circuits, then the thinking functions. And so this is really, in some ways, it's a, if it were to be a layered cake, it should be upside down. Intellectual functions should be at the bottom, but really here what it is showing is that the first level has to be preserved for the second level to function normal, and then for the third level to function normal, then the fourth level to function normal, and the fifth level to function normal. And if the first level goes, then all the other levels will be affected. And if the first level goes and the second and the third and the fourth are all impaired to begin with, as is the advanced stages of the neurocognitive disorders, then you can really imagine how easily you can change their capacity and their function. So this is the overview of brain and behaviors. And the reason I have given you this overview is because when you understand normal, now I can take you into pathology of these circuits in dementia and see what that does and what that creates, because this then allows you to understand behavioral expressions based upon which circuits and functions in the brain are impaired, for you to be able to have a better understanding, a better purpose, and a better meaning of a expression of behavior in individuals with neurocognitive disorder. So therefore, normal before we can go to abnormal. Okay, so now that we have made an effort to understand what normal is, let's try and go a little bit beyond. So having taken you through all of this journey, my goal was to introduce to you one extra term that is over and above what you guys talk about, which is the meaning. And so what I have introduced in my way of working is every behavioral expression has a purpose and every behavioral expression has a meaning. And the purpose is how you and I as caregivers, care providers, are interpreting those expressions. And then meaning is what the person with neurocognitive disorder is communicating to the caregivers or the care providers. And so the purpose and the meaning are two constructs in this that we will talk about more with examples. So here is sort of going back to the basics. We talked about the brain circuits, we talked about the brain functions, and so therefore what you have are these 5 things which we talk about: the regulation of sensorium, the preservation of information processing circuits, motivational circuits, emotional regulatory circuits, and the self-monitoring and regulatory circuits. And so if that's the case, then why not have a classification of behavioral expressions which arises from problems with these normal constructs? So basically this way we can say we understand this is how normal is, and therefore this is what we expect abnormal to look like. And so the first behavioral expression category that comes from is when there is impairment in the regulation of sensorium. And that behavioral category are the disorganized expressions. And the next behavioral category, which comes from abnormalities in the information processing circuits, are the misidentification expressions. The next categories of behavioral expressions which come because of impairment in your motivational circuits are goal-directed expressions, apathy expressions, motor expressions, and importuning expressions. And then the classification or the presence of behavioral categories which come from abnormalities in the emotional regulatory circuits are 3: vocal expressions, emotional expressions, and fretful trepidated expressions. And finally, the behavioral categories which come from impairment of self-monitoring and regulatory circuits are oppositional expressions, physical expressions, and sexual expressions. So in essence, what we've just done for you is, after explaining the normal and what runs the normal, we're going to try and understand behavioral categories which manifest themselves when the normal becomes abnormal in dementia, and could be any cause, whether it's protein, blood flow, or miscellaneous, and depending upon the advancement of the disease. And so, again, and so therefore, this is the behavioral scale, the inventory that I came up with. And again, for those who wish to know more about this and see more about this, it was validated. The validation study is on the website. And basically, it is a color coordinated scale. And, and, and if you remember, red was sensorium, purple was information processing, brownish orange was the motivational circuits, yellow are the emotional circuits, and green is the self monitoring and regulatory circuit. So in some ways, when we use this scale, the color of this also gives you a hint to which system this particular behavioral observation you're making belongs to. And what we're going to do now is we're going to go through each of these behavioral categories, starting with the red, then with the purple, then with the blue, with the orange brown, yellow, and then green. And each of these behavioral categories here has a purpose for you, your interpretation of what is happening, and a meaning, which is what the person with dementia is telling you. And so basically, there was a question put to me earlier if I have another scale. So in essence, what I am really saying here, guys, is we have some amazing tools in the kit, and we use them we use them at different stages. And the part where we are seeing the most behaviors and the area which is most challenging would be the area this particular scale has been specifically developed to fill that void. So many of us who work in the community, nothing changes because we're dealing with mild to moderate degrees of dementias, and we do what we do. And then when people come into long-term care and they happen to be in advanced stages and we are limited, then I am offering another tool because this is specifically focused on advanced stages, and it takes you away from the medical model, and it basically talks about behavioral categories which are based on psychological constructs, and those psychological constructs have been around in literature forever and on as the sensorium, regulation of sensorium, and the information processing circuits is the holy grail of neuropsychologists and is a part of the information processing cascade or the information processing theories, which are robustly laid out in the literature. The motivational circuits are derived from motivational theories, which are robustly embedded in behavioral psychology. So the first two belong to neuropsychology. The motivational circuits, which is a part of the motivational theories, because I'm sure people who have some degree of psychology background would remember from their undergrad days that motivational theories are powerful theories that tell us what motivates us and how we get motivated. And that is a part of the behavioral psychology. The emotional circuits or the emotional theories are a part of general psychology, and the social regulatory or the self-monitoring is a part of social psychology. So basically, this is all derived from stuff that is quite around. Hundreds and thousands of books have been written on each of them. They're all valid. We're simply taking it and applying them to a category of, or at a stage of a disease when clinical evaluation is a challenge. And if you are still able to do that clinical evaluation, guys, and you are comfortable in the validity of your approach, then carry on doing. You don't have to, consider what I'm offering, but if you feel that it's limiting you, then this is something. Okay, so let's move on to each of these behavioral categories.